Hello everyone, my name is Dang Feng. I come from Fujian Provincial Key Laboratory on Hematology, Fujian Medical University Union Hospital. Here is my email. I would be very happy that you can discuss with me about this lesson. Use the email after class. This course is divided into the following 3 parts. Now we will talk about the first part, cytological study of bone marrow. In this part, you need to understand the indications of bone marrow test, the process of hematopoiesis, the normal components in bone marrow, understand routine stain methods for cell chemical reactions. Now, please press the pause button and read the case carefully, and try to answer the 2 questions on the PPT, please. Occasionally, a disease of the blood cell system cannot be diagnosed and classified on the basis of the blood count alone, and a bone marrow biopsy is indicated. All clinically unclear situations need a bone marrow biopsy. It contains enlarged lymph nodes or spleen, changes in the simple CBC, and of course, sometimes we have to do the spatial test when a diagnosis cannot be made based on clinical findings, an analysis of peripheral blood diversion, blood analysis, cytochemistry, phenotyping, molecular genetics, or FISH. The site of hematopoiesis. Through the table, we know that the hematopoietic sites are different in different age groups. The site of hematopoiesis is basically in the bone marrow after birth, and with the growth of age, hematopoietic site mainly in the flat bone. Bone marrow contains yellow marrow and red marrow. The red marrow is the site of hematopoiesis. In addition to the peripheral blood matrix cells, there are also immature cells in the bone marrow. Choose the correct location for bone marrow aspiration or biopsy. Traditional adult at the posterior iliac spine and children at the sternum. Smears can be prepared on slides directly from the remaining contents of the syringe. Choose the appropriate staining, measure analysis, and write the report for clinical diagnosis. Now let's look at this picture. The various cells stored here can appear in the bone marrow. Bone marrow cells are mainly composed of 4 series: the red cell series, and the neutrophil series, and the megakaryocyte series, and also they have a small cell series. It contains eosinophils, basophils, lymphocytes, and monocytes. Also they have some plasma cells. Now let's look at the WBC maturation. As the cell's maturation, the cell size generally decreases, nuclear volume decreases. Nuclear maturation goes from round fine chromatin to segmented dark chromatin. Nuclear to cytoplasmic ratio decreases. No cytoplasmic granules to primary granules to specific granules. Now let's look at the granulocyte maturation. From this picture, we can find that the nuclear shape and the granule is very different from each other. For the lymphocyte maturation, the nuclear maturation is very important. It goes from round and fine chromatin to the segmented dark chromatin. Eosinophil. The color of the granule is orange, and it is rare in the bone marrow. Eosinophil will increase when parasitization, cancer phagocytosis, allergic response, inflammatory reaction. Basophil. The color of the granule is dark blue, and the granule can cover on the nucleus. Basophil will increase when immediate hypersensitivity reactions, some delayed hypersensitivity reactions, myeloproliferative neoplasms. Monocytes. Monocytes mainly consist of monoblast, monocytes. Red cell series consist of normoblast, basophilic normoblast, polychromatic normoblast, orthochromatic normoblast, and the red blood cell. Megakaryocyte. The function of megakaryocyte is to produce platelets. The number and ratio of megakaryocytes in each stage should be normal. Thrombocytogenous megakaryocyte, nucleus, platelet, and we can find that the thrombocytogenous megakaryocyte have at least 3 platelets connected with its cell plasma. Plasmacytes also have 3 stages: plasmablast, plasmacyte, and plasmacyte. We can see the shape of the cell. The nucleus always a side of the whole cell. At first, we use visual observation to choose a bone marrow smear with normal staining, appropriate thickness, and medullary granules for microscopic observation. We use lower magnification to judge the quality of bone marrow sampling, smear and staining, and to determine the degree of bone marrow nucleated cell proliferation and megakaryocyte count. Then check whether there are abnormal cells and blood parasites. There are 5 grades of bone marrow hyperplasia. Please remember all these dates on the table. We use the high magnification to check the grades of bone marrow hyperplasm. Now let's look at the cell density. Cell density increases while in all strong regeneration or combination processes, and in cases of leukemia and myeloproliferative syndromes. And cell density decreased in the blastic process and myelofibrosis. Choose a part with good staining uniform cell distribution, and clear morphology. The junction of body and tail to classify and count 200 to 500 nucleated cells and carefully observe the proliferation of each cell series, the number of cells, and whether there is any change in morphology. Erythroid granulocytic ratio. The important ratio of red precursor cells to white cells is 1 to 2 for men and 1 to 3 for women. Shifts toward erythropoiesis are seen in all degenerative anemias, myelodysplasias. Shifts toward granulopoiesis are seen in all reactive. Normal lymphoblastic anemia, myelofibrosis, multiple myeloma, lymphoma, anemia of chronic disease. According to the observation results under the microscope, combined with relevant clinical data, comprehensively analyze and judge, draw appropriate conclusions, and fill in the bone marrow morphological diagnosis report. There should be a balance between cell production and cell death, except at the times of requirement. Loss of balance can cause many diseases. Now let's look at the normal bone marrow morphology. The nucleated cell proliferation is active. The GE ratio is 2 to 4 to 1. The percentage of nucleated cells at each stage of each line is basically within the range of normal reference values. There is no obvious abnormality in the morphology of various blood cells, no parasites, and obviously abnormal cells. Cell composition in the bone marrow. Normal values. We can see that all stages of red cell series and neutrophil series and megakaryocyte cell can appear in normal bone marrow, and the small cell series only contain the mature stage that just like the peripheral smear. Now I will talk about anemias from definition, cause of anemia, laboratory findings, classification. A reduction in one or more of the major RBC measurements, hemoglobin concentration, hematocrit or RBC count. The hemoglobin level of newborns decreased gradually in the first month. 3 months later, it began to rise. Older males are higher than women. Prevalence was greater in females than males in all ages. Most frequent in children less than 5 years old. Anemia was most frequent in South Asia and Central, West, and East Sub-Saharan Africa. The main causes are iron deficiency, sickle cell disease, thalassemia, the anemia of chronic disorders. Red blood cell is produced in the bone marrow, then enter to the circulation and remove after 120 days. If the produce reduce or remove increase, both of them will cause anemia. So, what can reduce the production? What caused the decreased erythrocyte production, decreased erythropoietin production, and inadequate marrow response to erythropoietin? From the picture, we can find that the EPO level is also very important in produce of red blood cell. Decreased erythropoietin production, inadequate marrow response to erythropoietin. So the renal disease can cause the anemia too. The material, just like the iron, the protein, or the vitamin B12, will reduce the production, and the remove increase happen at hyperplatinum, autoimmune hemolytic anemia. What can we find from the laboratory? We may focus our eyes on the reticulocyte count, blood film, and bone marrow examination. There are many kinds of shape abnormality which can cause the red cell reduce and destruction increase. Another teacher will give you the detail about the blood films. And abnormal shapes are also associated with some disease. If you want to know more about this, you can email me and I will get back to you. Bone marrow examination. The proportion of the different cell lines assessed. Myeloid erythroid ratio. The proportion of granulocyte precursors to red cell precursors in the bone marrow. Normally 2.5 to 1 to 4 to 1. Cellularity. Megakaryocyte count. The percent of foreign cells. Secondary carcinoma. Small hemoglobin poor erythrocytes indicate iron deficiency. Bone marrow cytology in iron deficiency anemia shows only increased hematopoiesis and left shift to basophilic erythroblasts. Absence of iron deposit after iron staining. This one is iron staining and absence. We usually classify anemia in 2 ways. The first one is morphology. The other one is pathology. The first one is more common, and the classification depends on the value of MCV, MCH, and MCHC. Now we talk about the normal morphology of erythrocytes. This table is very important. Please note what the range of MCV and MCH values are for each type of anemia, and what the diseases are. You can also look at your book on page 265 to 266 and generalize it, then go through the chart yourself to help you remember it. Blood film of microcytic, non-microcytic, and macrocytic. The macrocytic white cells are bigger than the normalcytic, and the cell size are smaller. And the macrocytic size cells are bigger than normalcytic. The investigation of a microcytic hypoglomic anemia. The division comes from the blood film, then the serum iron, and make decision whether we need to do bone marrow aspirate. Investigation of a Normalcytic Nomogromic anemia. The point is the reticulocyte count. Acute. I mean it is a proliferative anemia or incompensatory period of anemia. If the retic is normal, bone marrow is normal, then it is the problem of the secondary anemia. The retic normal or lower, bone marrow morphology are normal. It may be a malignant disease. Macrocytic anemia. The retic is normal or lower. The bone marrow is required to check whether it is MDS or deficiency of vitamin B12 and folic acid. Normal red blood cells are biconcave discs. Iron deficiency anemia is characterized by small cells that central white areas enlarge and varying cell size. Small, big. Megaloblastic anemia, the size is very big. This one. And some other species are normal shapes, just like this. Now let's learn white blood cell disorders together. Leukemia is a group of malignant disorders affecting the blood and blood-forming tissues of bone marrow, lymphoid system, and spleen. At the beginning of our lesson, I have shown you the cases that have affected the blood. And leukemia can occur in all ages. Biology of leukemia is resistance to apoptosis, even when DNA is damaged, deregulation of growth, and differentiation block. Cell differentiation block and resistance to apoptosis. Then become to a cancer stem cell and monocular cells proliferate quickly. The proliferation of leukemia cells inhibits the growth of other bone marrow cells. So, what stimulates the cell differentiation block? Chemical agents, chemotherapeutic agents, virus, radiation, immunologic deficiencies. Leukemia. There is no single causative agent of leukemia, most from a combination of factors, genetic and environmental influences. What stimulates the cell differentiation block? Chemical agents, chemotherapeutic agents, viruses, radiation, immunologic deficiencies. Leukemia is divided into acute leukemia and chronic leukemia. Acute leukemia, clonal proliferation of immature hematopoietic cells, the formation of blood or blood cells. Chronic, major forms of WBC. Onset is more gradual. The left is acute leukemia. It is poorly differentiated blood population, rapidly fatal outcome if untreated. The right is chronic, well-differentiated cell population associated with longer survival, even if left untreated. We use the type of white blood cells. We classify the acute leukemia to acute lymphocytic leukemia, acute myelogenous leukemia, also called acute non-lymphoblastic leukemia, chronic myelogenous leukemia, chronic lymphocytic leukemia. Acute leukemia will present with signs or symptoms related to cytopenia. WBC reduce or normal or increase that have no function with infection. The hemoglobin reduce, anemia, platelet decrease, bleeding, and organ infiltration. The lymphadenopathy, splenomegaly, hematomegaly, and the central nervous system. Most of these happen more common with ALL than AML. Now let's learn about acute lymphoblastic leukemia. The laboratory findings of this disease, we can find that red blood cells hemoglobin normal, moderate, markedly lower, white blood cells high, normal, lower. In children with high WBC, leukemic blood cells present, and platelets usually lower. The character size of the blood cells determine the degree of reduction of normal hematopoiesis. And the WHO usually uses the morphological, immunological, biochemical, and chronometric analysis to classify the disease. The FAB classified the ALL according to the size of the leukemia cells. ALL1 is the small cell ALL. The ALL2 is large cell ALL, and the ALL3 is also large cell ALL, but no granular in the plasma and have many balloons. Now, the ALL3 is not diagnosed to ALL, but bucket lymphoma. This table summarizes the cytochemical staining characteristics of acute leukemia, which you can remember well. Acute lymphoblastic leukemia, all the chemistry are negative except for PAS staining. Here is the important conclusion of leukemic cell cytochemical staining characteristics. The ALL, the PAS is very strong positive, and AML is sunburn black and the POX positive. POX negative means the positive cell less than 3%, and when we get a picture, we always get positive cells to make sure our examination is successful. This one is positive, and all of this is negative. So the ALL, the positive is less than 3%, and we examine the leukemia cell, but not the normal cells. Leukemia cell immunological characterization. Just look at this picture. And now this is the leukemia cell cytogenetic characterization. Acute myelogenous leukemia is heterogeneous group of malignant hematological precursor cells of the myeloid, monocytic, erythroid, or megakaryocytic cell lineage. Acute myelogenous leukemia by FAB classification also come from M0 to M7. Classification of the acute myelogenous leukemias by morphology, cytochemistry, and immunology. The morphology result is nearly to the ALL, but the immunology is very different with ALL. We usually use the WBC type and the percentage of blast cells to classification M0 to M7. Except M0 and M7, the POX are positive in AML. POX of M3 is very strong, and we can find all body in the plasma of the leukemia. This table is the cytogenetics of AML. Now, let's go to the bleeding and thrombotic disorders. There are three causes of bleeding: platelets, blood vessels, wall, and coagulations. The function of platelets are adhesion, activation, and aggregation. Platelets in the process of physiological hemostasis can be roughly divided into two stages. The first stage is immediately after the occurrence of trauma. Platelets quickly adhere to the wound and gather into a group, forming a relatively primary hemostatic plaque. The second stage promotes blood clotting and forming stable hemostatic plaque. Platelets are produced by megakaryocytes. Each megakaryocyte giving rise approximately to 1,000 to 500 platelets. Overall, 2/3 of these newly produced platelets will remain in circulation, while 1/3 will be sequestrated by spleen. The normal platelet count is approximately 150 to 400, and the normal platelet lifespan is 10 days. Here is the normal value of platelet count. Prolonged bleeding times are generally found when platelet count is below 50,000. Platelet dysfunction. The bleeding time meter is usually used in the forearm. The usual time is about 1 to 3 minutes. Thrombocytopenia is seen in a variety of diseases, including the acute leukemia we have discussed before. Increased destruction of platelets in ITP, drug-induced, and TTP. Idiopathic thrombocytopenic purpura is the most common cause of thrombocytopenic without anemia or neutropenia. It is usually idiopathic but may be seen in association with other diseases such as SLE, HIV infection, hepatitis. Now let's go to the coagulation cascade. After platelet aggregation and release, the exposed membrane phospholipid platelet factor 3 is available for two reactions in the coagulation cascade, extrinsic and intrinsic. So this is the table of the whole coagulations. After the vascular damage, the tissue factor exposed to factor 7, collagen exposed to factor 12, and start the coagulation cascade. Now, please look at this page. Tissue factor is expressed at skin organ surface. Those are extravascular, so it initiates pathway called extrinsic pathway. The vascular injury and expose the collagen and release platelet phospholipid, which initiates the intrinsic pathway. So this is the pointing of coagulation cascade. Call your own memory about coagulation cascade. This page summarizes the cascade activation of the extrinsic and intrinsic pathways. Generation of thrombin is the common pathway of extrinsic and intrinsic coagulation pathway. They generate the activity factor 10 together with factor 5 activity phospholipid calcium formed prothrombin complex. Activate it, prothrombin generates thrombin. This is the summary of coagulation cascade. Now let's look at coagulation laboratory test. Point please. One title of the final exam will come from here. Screening test of blood coagulation is PT, APTT, TT, and the specific assay of coagulation factors, factor assay, and the test of fibrolysis. So the screening test is cheaper than specific assays and the test of fibrolysis. Before we can check which coagulation factor the patient have deficiency, so we can do the screening test for the patient who have bleeding disease. Look at this picture carefully. Think about the coagulation factor of extrinsic and intrinsic pathway. Please just answer the question what the red words are and the blue and the green words for. APTT screening test for extrinsic pathway, PT screening test for intrinsic pathway, TT screening test for the prothrombin to thrombin. Configuration test is expensive, so when the screening test is abnormal, we can choose the factors to test, then combine with the clinical history and symptoms to make the diagnosis. This is the configuration test and the abnormal values for the disease. Configuration disorders, we only talk about hemophilia A. Hemophilia A is the most common of the hereditary clotting factor deficiencies. The prevalence is of the order of 30 to 100 per million population. The inheritance is sex-linked. Up to one-third of patients have no family history, and these cases result from recent mutation. The defect is an absence or low level of plasma factor VIII, so please tell me which screening test will be abnormal. Half of the patients have frame-shaped mutations or deleting in the gene. Laboratory findings of hemophilia A that PT is normal, ABCD is increased, and the factor assay can show you that factor VIII deficiency. Thank you very much for everyone studying online. And if you have any questions you want to discuss with me, please just contact me with the email. I have shown my email address at the first page of this PPT. Thank you very much.